Hello and welcome back to Bedside Murmurs, a podcast where we chat with doctors about their careers, pathways in medicine, clinical tips and much more. If you have any questions or any ideas for guests that you would like to see on the show, you can send us an email at podcast@medsoc.org.au or direct message us on Instagram at Bedside Murmurs. I'm Emily.
And I'm Sean, and we will be your hosts. Today we have the pleasure of speaking with Dr. Rob Page, who is an addiction medicine specialist. He has trained as a general practitioner and has special interest in addiction medicine, sexual health, and HIV medicine, and works at a variety of clinics across Sydney. Welcome, Dr. Page.
Thanks for having me.
So where did you grow up and what inspired you to become a doctor?
I grew up in country Western Australia in Northern Territory. So I was born in Fremantle in WA, moved around as a kid to Kalgoorlie in the Goldfields, Northern Territory, a little island called Groot Island in the Gulf, and up in Newman in the Pilbara. And then went to boarding school down in Perth and didn't really know very much about what I wanted to do, but was, got pretty good marks, was reasonably switched on and figured I'd try for med. Got in and sort of went from there. I was speaking with Emily earlier and said, look, I found med school a bit tough sort of halfway during, and I was a little bit uninspired, so then had a bit of time away from it, and I think sometimes that's enough to sort of give you perspective. But kind of a bad answer, right? I was smart and I got reasonably good marks, so I figured I'd have a go.
That's actually I think a lot of people have that kind of idea going into medicine as well, as more than many people might think. I think the way medicine is structured is that if you get a good mark, there's no other course that's even close in vicinity to the ATAR requirements for Australia or the mark requirements anywhere else in the world to get into medicine. And when you have a really nice mark, you kind of
it's like, might as well try it.
You're inspired.
Exactly. I like to challenge, and I was lucky enough to get given a place. So,
Yeah. And where did you go to medical school?
University of Western Australia. So, boarding school down in Perth and straight into med school there. I was pretty young. I started med school when I was sort of 16, 16 actually, turning 17.
Whoa,
so
that's very
reasonably young. You graduated a year early in Western Australia, but started pretty young. So
you'd be a year early and also 16.
Yeah, I was turning 17 in my first year, but even so, yeah.
Wow.
Yeah.
What was it like kind of graduating at you took a gap year in between?
That's right. Yeah, it was. I sort of got a little bit. I guess I don't know how personal you want me to go, but I found life pretty tough in my first few years of med school. I was figuring out that I was gay, and all that sort of stuff got a little bit rough for me, and so I needed a bit of time and space. And I think being young and starting and all the pressure that comes with med school made it pretty difficult for me, as well as being really smart and good at stuff in high school, and then going to med school with lots of other geniuses, and you're very much middle of the pack, if even that. And then I took some time away from it and worked hard and moved out of home, and that sort of made a big difference, launched me back into it, and was really, really keen just to do it on the other side of that. And did really well, and came at the other side feeling a lot better about it and really excited to be a doctor. So
that's such an encouragement, because I think a lot of people do struggle in medical school and often don't voice it or just plough through. And so I think that's really wise, actually, that it was good to think about some life things and also take some time off to refresh and rethink. So, thank you.
Thank you. It worked for me, yeah. So.
And also that it's completely okay to take a few years off in the middle. It feels like when you get into medical school that you're just barraging forward, and if you miss a year, oh no, you're going to be late to everything else. And that's not true, clearly.
We've spoken to so many guests, and so many of them have taken a gap year or done something different. Does make a world of difference, really. Yeah,
when I'm talking to my med students and I'm like, so what do you want to do when you finish med school? And they all say, I don't know. I'm like, no, that's exactly the right idea. When you're in the middle of med school, you should, I think, have a really open mind about what you want to do going forward, whether that's kind of medicine or not. I still think it's okay. I had friends who finished med school and then did completely different things. And that was, I don't know, maybe I shouldn't be saying this on a medical podcast, but I kind of respect them for that, right? It can be really tough figuring out which direction you want to go in. But medicine is a great choice, and I'm really glad with what I've ended up doing. But if it turns out not being medicine, that's kind of okay too, right? Yeah.
And did you have any idea of what you might do after medical school?
Not
when
at
you were
all.
In medical school?
No. I really liked just about everything that I did, except I apologise to my sort of surgical friends and colleagues. But it was super interesting, but I kind of knew that doing surgery wasn't going to be for me. But emergency medicine, general practice, like the very small amount of addiction medicine stuff that I did, like the internal medicine stuff, pediatrics. I really liked all of it. So I never could figure out what I wanted to do when I was at med school. So, and then I became a junior doctor and just tried a whole bunch of things before I eventually settled on what I ended up doing.
Yeah.
Surgical specialty seems to be the great separator for medical students.
Yeah, look, it's different, right? Like I have so much respect. It's such a tough gig, and it's really, I think, really difficult, really challenging, both to do the training program, get through the exams, do the experience that you need, and then be a good surgeon at the end of it. So huge props to them. But it's just not for me, but that's okay. Like that's the good thing about medicine. There's really cool, interesting things. I think no matter the sort of personality you have or the way you think about things or the way you like to work. So yeah, we're luckily like that, right? Yeah.
Yeah. And so what training did you end up doing after medical school when you were a junior doctor?
Yeah, so I did a general, we all have to do general internship years, right? Then a general residency year, an SRMO year that sort of focused on intensive care and emergency medicine and anesthetics sort of stuff, because I thought that was the direction I wanted to head in, but found shift work fairly punishing and realized that I didn't think I could probably handle that for too much longer. Although stupidly, I then wanted to save to travel, so I did a year and a half of local emergency medicine work, which was all shift work. I mean, really good fun, and I got some great experience. But after that, again, realised that because that would involve shift work, if I was going to do emergency medicine forever, it probably wasn't to my taste. But I did like the general aspect of both that and internal medicine and and general practice rather. So if I was going to choose one of those without as much shift work, GP was probably the way to go. So that's what I started doing first.
And how did you find GP training?
I really liked it. Yeah. General practice is fascinating, right? Like you get to learn a large amount about just about every single system. And I mean, medicine is just really cool and fascinating. So you get to learn about all the diseases with a reasonable depth and get to see all sorts of different patients across the lifespan, sort of tiny little babies all the way through to older people. And if you want to go and do nursing home work as well, you can, or work in emergency departments or whatever else it might be. So I found it really, really cool. And through it, I was able to go and do work so I did my extended skills, and I did that partly at a clinic called Kirkton Road Centre, which is a homeless health clinic in King's Cross. And so that's where I first got exposed to things like sexual health medicine and HIV medicine and addiction medicine. So we were serving lots of people so it's a clinic that was started in the 80s in response to the HIV/AIDS crisis that was around at that time, focusing on those groups at particular risk of contracting HIV/AIDS. And so we're seeing lots of people who were injecting drugs, people who were sex working, men who have sex with men. So that was a really different way of practicing in primary care. But yeah, very, very cool, and a really great team to sort of show you what providing high quality healthcare for vulnerable populations looks like, how to do that and how to do it well. So that was really cool.
Wow, that's really cool.
Yeah.
And did general practice then allow you to specialise in addiction medicine, and what was that path like?
Yeah, that's right. So I did that year at KRC, and then I went out to the country actually and worked in an Aboriginal health service for a year up in Moree. So Pius 10th AMS in Moree. So that was a long way from home, but really cool. An excellent service to give you good quality primary health care experience. And so finished my GP training there, got my fellowship, and then wasn't entirely sure if I wanted to work in gay men's health or HIV medicine, sexual health or drug health. So I figured I don't know, do a bit more study and do a Master of Public Health, and did that while working there, and then further working as a GP in inner Sydney in private practice, as well as working at Kirkton Road Centre. And that's one wonderful thing about general practice, right? You can work a couple of days and do some study and work across a couple of different services. And so, I did my MPH, and then after that I thought, addiction medicine's a space where I think people who use drugs in Australia often struggle to engage with the healthcare system. Well, I think certain populations of people who use drugs, right, particularly people who inject drugs and people who are opioid dependent. And I think are sometimes not as well served by the health system as they could be, and experience significant stigma. So I thought, okay, that'd be a cool space to move into, just to, I don't know, be part of the change that you want to see, right? So see if you can be one of those doctors that people feel a little more comfortable coming to speak with about their issues. So yeah, did addiction training while I was working as a GP through Kirkton Road Centre, and then worked in South East Sydney LHD at one of the clinics there. Got my fellowship in addiction too, and yeah, been working as a staffie ever since across a couple of different places. Yeah.
Wow, that's amazing. And it's so nice to hear you thinking about how your skills in medicine could be used to really serve those vulnerable populations who really need healthcare the most, but actually it's just there are often more barriers and things like that. So it's great to see you being the change that's needed to actually facilitate that engagement. So that's fantastic.
Thanks. Yeah, I think if we all think about it, like we've all got skills, and I think we can probably all find those little parts of the system where we can use our particular skills to hopefully, like plug those little holes where people aren't as well served as they might be. But thank you. Yeah.
What does working in addiction medicine look like for you?
I see people who have opioid dependence for the most part. Most of the time in Sydney, that's heroin dependence. And for the most part, you're seeing people who have, for one reason or another, ended up using heroin in a dependent way, and they're sick of the amounts that it's costing them, whether it's financially or in other ways, the overdoses that they're having, how thrashed their veins are from injecting, the hepatitis and whatever other conditions they might have ended up with as a result. And they want to either cut down or stop their heroin use, or find ways to reduce the risk of all of those bad things happening to them. So we aim to engage them and generally stabilise them on some form of pharmacotherapy and help them with the other health needs that they might have. So whether that's treating their HIV or their Hep C, or treating the infections that they have related to injecting, helping them towards housing, managing their anxiety and depression, those types of things. So that's the majority of my work. And there's a lot of that work. Yeah, there's lots of people who have opioid dependence who struggle to get into treatment, so will never want for work. So that's my clinic work. And then also I do consult liaison work. So that might be seeing people who have been admitted with a broken hip who are alcohol dependent, and we assist the orthopaedics team with managing the alcohol withdrawal while they're in hospital. It might be assisting the mental health team with people who have amphetamine dependence who ended up in hospital with drug-induced psychosis, and lots of other things that happen in hospital where people have intoxication or withdrawal syndromes that need managing. Yeah.
Yeah. Also, like adding to that as well, it's kind of things that we don't really think about in a hospital setting when a patient comes into the emergency room, how much of their symptomology might be as a result of being in a hospital setting and the withdrawal from whatever substances they were using normally. And that aspect of it is critically important to their care, but not often think about and not often taught very, very well in medicine as well.
Yeah, I remember when I was at med school, I had one day of drug and alcohol exposure as a medical student. I remember it really well, but like it was one day out of 6 years, but it stuck with me. And I think like I think the UNSW med school course, like if you elect to do it, then you can have sort of 4 weeks in a drug and alcohol service, but not everyone gets that. I don't think.
It's also very small, like proportion of the people that actually manage to be able to get in anywhere.
Yeah, exactly. And I mean, it's definitely getting better though, I think in particular for junior doctors. So us as like the drug and alcohol service within South East Sydney, like we go to the hospitals and to other health services and provide training and guidance on identifying and managing problems related to substance intoxication or withdrawal. And in my experience, I mean, even just since I was at JMO to now, people I think are much more experienced and capable in identifying the issues as they arise and sort of realizing the problems that people with substance use disorders might have engaging with the healthcare system and in helping people to both, I guess, feel less stigmatized, but also get on top of whatever it might be, the anxiety related to alcohol withdrawal or the opioid withdrawal symptoms that they're facing. And I think also the health care staff that are seeing them are aware that we exist as an addiction medicine team and are happy to pick up the phone and say, hey, I've got this issue, I don't know how to fix it myself, but what should we do? So yeah, it's imperfect, but I think it's certainly getting better. Yeah.
What have you found to be the most enjoyable parts of your job working as an addiction medicine specialist?
There's lots. I think I've referred to a few of them already, right? Like it's those people who come in and they say, "Look, nah, I hate doctors." They'll say that straight to me, and I'm like, "Yeah, that's like I get that. That we get that quite a lot because of their experiences being so poor in trying to engage with the healthcare system." And like you can, I guess you can see it from the doctor's side as well, right? If they've seen doctors and they've been saying, "Hey, I want this medication or this medication," they get dismissed as a drug seeker. The doctor's unhappy because they've been seeing someone who's a drug seeker. The patient's unhappy because they've been turned away for whatever reason. So if you're able to then see those people and engage with them, try and establish why they might have those patterns of behavior and might be saying those things, and try and meet them where they are and see what they're trying to get out of engagement with the health service and provide them with that, especially where they weren't feeling like they were able to engage with the healthcare service before. That's really, really rewarding, right? Like speaking with those people and giving them a good experience and allowing them to access high quality healthcare. Because I mean, I maintain really strongly everyone in Australia, and I mean, ideally in the world, but let's deal with what we can, right? Like everyone in Australia should have the right to high quality healthcare. We've got a fantastic socialised healthcare system, and we should be doing our best to make sure that everyone is able to access that high quality healthcare. And if you can provide that to people where they couldn't before, I find that really, really cool. Yeah.
And also to be able to feel comfortable seeking it if they need it as well.
Yeah, that's right. Like giving people a place where even if, I don't know, maybe you couldn't give them what they wanted that day, but if they know that, okay, there's someone there that will listen and that will do their best to help me within the limits of what the system can provide, that's great for people to feel open to do that. And then hopefully will feel more comfortable engaging with the system at large about their issues, right?
Yeah. What have you found to be more challenging aspects of the job, or things that you didn't expect when you first started?
The challenging things, there are often those situations where just the system is really incapable of providing the assistance that people might want or might need. I mean, you sort of might say, okay, you'd really benefit from this particular form of structured psychotherapy or this form of drug and alcohol rehab or whatever else it might be, or this type of pharmacotherapy, but it's either not available on the PBS, or the wait list for the type of psychotherapy that you want might be, I don't know, months, or it might not be available publicly, or the availability of the rehab might be sort of 3 months, 6 months, or a year away. Those are the really challenging parts for me. I mean, I think most people probably expect you to say something like, I don't know, seeing intoxicated people or people who are really aggro or aggressive or those sorts of things. I don't know, maybe it's like, I don't think I've become inured to it. Like if someone gets cranky with your abusive or aggressive, then like, yeah, that always stings and is tough and hard to deal with. I feel like I'm pretty capable and pretty good at dealing with it these days, but it's like, honestly, it's mostly just a manifestation of past trauma amongst people who've had a really, really rough lot of it and that are just looking for a way to express themselves. I'm not trying to defend, I don't know, aggression or abuse towards healthcare staff, clinicians or med students, right? Like it's unacceptable. But if you look at the reasons why people with, I don't know, mental illness or people with substance use disorders maybe manifest such behaviours more often than people who don't have those things, it's not because these are bad people, it's because these are people who are often heavily traumatised and are in the midst of feeling absolutely horrible because of the things that they're trying to deal with and are trying to get through based on the behaviours that they've learnt or been brought up with. So even though you shouldn't excuse it, trying to explain it sort of helps to deal with it in the day to day.
Yeah, it sounds like your main gripes with it is not with the patient, but with the system that has led to whatever problem is causing it.
Yeah, that's right. If you look at the people who end up with problems related to substance use, I mean, people who have had multiple adverse childhood experiences are dramatically more likely to end up using substances in problematic ways. And that's not the fault of the kid who had these adverse experiences, right? That's just the fact that we've got a quite unfair and tough society at times that leaves kids in these situations that then end up as bruised and traumatized adults who are more likely to reach for substances to try and deal with the things that they experience in life. And yeah, that's a systems issue, right? The kids end up in this situation rather than any failing of those children.
We've spoken a lot about treatments and different places that people can go for help, but you've also been involved in harm reduction initiatives and prevention strategies, especially as a GP and doing a Masters of Public Health. That would have been really forefront. Could you tell us about some of those initiatives you've been involved in and what you've seen in that kind of work?
Yeah, for sure. When I was at KRC, sort of back when in sort of I think it was 2015 or 2016 or so, I was involved as one of the very, very low level. There were much cleverer people way above me, but like a very low level sub-investigator, doling out prep to, so assessing people for HIV pre-exposure prophylaxis medication, so tablets they can take to reduce their risk of contracting HIV amongst vulnerable populations, populations at risk of contracting HIV. And that was great, right? This approach that had been taken in places around the world, and the powers that be, to their huge credit, invested huge amounts of money in rolling out this enormous trial to put these medications in the hands of people to reduce their risk of contracting HIV, and it was tremendously successful. I mean, it's been cited around the world many times, so that was great as sort of my first real foot in the door when it came to research. And since then, again, being involved in research trials involving things like, I don't know, giving out naloxone packs to people to reduce their risk of opioid overdose, or finger prick tests for HIV and Hep C were very cool as well. But more recently, I stepped up and took the leadership position for a research project allowing people who use Sydney's Supervised Injecting Centre to be able to get their drugs tested to find out their constituents. I imagine your listeners probably know about the Injecting Centre, do they?
Yes.
Yeah, great. Yeah, so for a long time now, New South Wales has been at the forefront of harm reduction in this particular space. I think it was the first supervised injecting room in the Southern Hemisphere, and one of the first ones in the English-speaking world. And for more than 20 years, they've provided people with a safer place to inject drugs, and if people have overdoses, get them managed. But then people are still left, because we have the illicit drug market bringing drugs that people don't know the constituents of, and just taking the chance that it's something that might be less or more harmful or might have no active substances in it at all, right? So I think another part of that puzzle then is giving people the knowledge about the drugs that they're bringing in, so they can make more informed and hopefully safer decisions about the drugs that they use. So we did that over the course of sort of 4 or 5 months or so at the Injecting Centre last year, which was, very neat to be able to do this thing for the first time in New South Wales.
Wow. And what did you find from, I guess, the trial, and will that be something that continues at the centre?
We found that it's something that people really want. So almost universally, people who had their drugs tested there said, yep, this is great. I'd like to have this available every time that I come to the Injecting Centre. It was successful in linking people into treatment, or having people accept referrals to treatment. I mean, having people sit down. It was me doing the results delivery. I had a clever chemist colleague sitting next to me, testing the drugs. I don't know anything about how to do that. And then I'm sitting there conveying the results to them and talking about what applicability that might have to them. And through that, people accepted referrals to treatment, or were able to engage in conversations about safer drug use and those types of things. We put naloxone in people's hands. And I mean, as far as what the drugs that we found were, Sydney's drug market, I don't know, I was kind of surprised. People almost always had what they thought they had, right? Not that many contaminants really. We didn't find those really, really dangerous things that they see in North America, like fentanyls and like the other potent synthetic opioids, which is a good thing, right? It means that our drug market is not as toxic and not as dangerous as that in North America. But I think the good thing about piloting this type of approach early is that we can see that it's something that is really acceptable to people who inject drugs. People want to be able to access such a service. And if we do start to see more drug market contamination in Australia, then we know this is something that could fairly easily be implemented, because people are going to want to use such a service. As far as whether it next leads to people being able to test their drugs at King's Cross, I am unsure as to whether that will be possible at this point in time. There's sort of other approval type questions that come into play there, and we sort of got approval with a very tight research focus,
gotcha.
under sort of university ethics approvals. And so as far as launching an ongoing service, that's, I guess, probably a question for the folks at the injecting centre. But as far as like first steps in a pilot, I don't know. I think it was successful. I'll be talking about it more at conferences shortly and publishing hopefully later in the year. So watch this space.
Oh, that's fantastic to hear.
That would be really, really nice. And also, I think there may be some arguments like, you're kind of helping or enabling people to do like substances, and it's clear that they're probably going to find some way to do them themselves. And if we can find a safe way for them, that's better for everyone involved.
Yeah, it's a commonly presented concern about drug checking or pill testing or whatever you want to call it. And it's this type of approach has been used around the world for decades, mostly in festival environments, mostly for people who don't inject drugs, right? And so I would argue that this is really quite a different population who have mostly been injecting drugs for a long time and who are on an almost daily basis, if not a daily basis, bringing drugs in that they have every intention of putting in their arm with a needle. And if we can give them more information about that, I think, look, there's one of two possible outcomes, right? They're going to do what they were going to do anyway, which, I mean, I don't know, you've had a bit of a chat with them, made sure they've got naloxone in hand, had a talk about safer injecting. Or you might be able to say, hey, this has actually got this other cutting agent, and then they might use less or might use none at all. If they're going to use what they were going to use anyway, I mean, hey, kind of no harm done really. They're doing what they were doing. But if you're able to help to reduce or stop someone's substance use if there's something highly toxic in there, I think that's great. And without someone knowing what's in their drugs, it's pretty difficult to allow people to make those decisions.
Yeah, absolutely. And what do you think are some of the other big misconceptions that the general public might hold about addiction or addiction medicine? And how do you try to address those misconceptions in your job?
Some of the big ones are just around what we do in addiction medicine. So people think of it, and I mean, just the conversation that we've had so far, I think, and this is partly my fault, is that addiction medicine is all about heroin and all about meth and all about like the bad drugs, the really hard drugs. And I guess I work as the lead of an opioid treatment program, so that's heroin's what I focus on. Yeah. But the majority of treatment episodes related to alcohol and drugs in Australia are focusing on alcohol, right? And alcohol is far and away the most problematic substance when it comes to issues around hazardous use, harmful use, impact on health, causing hospital presentations, contributing to violence. Alcohol is the biggest issue. So people sort of think about who I might be seeing in my day-to-day, and people sometimes, if they don't know me very well, use quite disparaging terms when they're talking about who I might see in my day-to-day. But for the most part, yeah, it's people who are using alcohol, and it's sort of just crept up on them, and it's gradually become an issue. So yeah, addiction medicine, alcohol is the biggest amount of work that we have, and often it's I think with alcohol and many other drugs as well, the people that are engaging in care, they might not be the people that most people would think, right? People generally think of people going to drug and alcohol clinics as those people who are sleeping in the gutter, who are homeless, who are, engaging in things that many people in the population might consider to be unsavory. And I think that's, a horrible amount of stigma related to what people think about people going to alcohol and drug services. But yeah, a lot of people coming to drug and alcohol clinics, I mean, people who use alcohol and drugs are from every cross-section of life. I mean, if you look at who uses alcohol and drugs in Australia, as far as illicit drugs go, 47%, I think at last count, of the Australian adult population have used illicit drugs at some point in their life. And these are people who come from all income brackets, who come from all walks of life, who use drugs and who end up with problems related to drugs. And so, yeah, it's nice to kind of put paid to that vision, that idea that alcohol and drug patients or people who use alcohol and drugs have a particular look or have particular characteristics, because they come from everywhere. They're all of us.
The stigma also makes it less likely for people who might need the help to seek the help that they need as well, because they're like, oh, I don't want to be known or seen as the person that is seeking that particular type of help, mostly just because there's stigma in the name.
That's exactly right. Yeah. People are really reluctant to come to a drug and alcohol service in the first place. Or even when we're there in the hospital emergency department, they say, no, I don't want to talk to the drug and alcohol team. I'm not a insert pejorative title here, right? I'm not one of those. And so, yeah, that's something that continues to be an issue. And I think will take longer to break down, but that's all right. That's just all have to continue to work away at it.
Yeah. Also, I think in addition to that as well, just on the slide of alcohol, it's so, I don't want to say rampant, but it's very ubiquitous.
Normalized in Australian
definitely.
society. Yeah.
Like all of our university events are, if not like mainly, the fact that
Centered around,
the fact that alcohol companies have some kind of sponsorship inside our university events is probably a big red flag already.
So not much has changed in 20 odd years since I was at uni then. Okay.
If anything, it's profitable because we're the target market.
Yeah.
So understandable sponsorship. So no problems there, but you know, it's a sign of the ubiquity. Also, I think if you are someone that doesn't drink, or someone that chooses to not be a part of like alcohol related activities, your pool of possible like things that you're invited to also has dramatically shrunk. And if your friend group is with a lot of people who do use alcohol to enjoy their night, then you not drinking alcohol kind of puts into stark contrast their use as well. And sometimes you might get yourself ostracized. So it's a very complex issue.
Yeah, that's interesting. It's been you can see my grey hairs. It's been a little while since I was at university, and I don't know. I wonder if it's changed. I'm sure there's research out about it. I wonder if because when I was at uni, very much social events centered around alcohol. The uni clubs sort of, that was the thing that they were famous for, getting as boozed as possible. I wonder if it's different, if it's better these days, if you're either drinking little alcohol or if you're abstinent from alcohol, if there's more of a space. I don't know. You'd have a better knowledge than me.
I personally think there is probably more of a space. There is been more chats about it. I remember in MedSocs, we when we do talk about like now med camp, we do try to think like, oh, if somebody is not absolutely wasted, what could they do at night? So the conversations are kind of like slowly creeping in. That's not to say that the main intention of these activities still is like all the scrub crawls and pub crawls. The intention of it is to go to a pub for the express intention of drinking alcohol. So that is still a major part of it.
Yeah. Interesting. Yeah. Our society will take a long time to change. Alcohol is still like the cheap, safe, legal drug in many people's minds, right? I mean, despite the fact that there is no sort of safe lower drinking level, despite the fact that most alcohol consumption, especially in binge patterns, is hazardous if not harmful. But it's pretty difficult to get that through people's minds, especially if you've never experienced any significant harm yourself, or if you don't perceive that you have. It's a hard message to convey, especially to people between the ages sort of 15 and 30 or so, right?
You're kind of immortal then.
Yeah, exactly. Well, if there's a big disconnect between the action and then the negative consequence, then I mean, it's pretty hard to break through that, whether it's related to substance dependence, and especially things like nicotine use or tobacco use. It's pretty hard. That's the adolescent mindset, right? It's hard to get through that, but yeah.
And I guess moving back to clinical medicine, do you have any suggestions or tips for medical students who might be about to start an addiction medicine rotation and not really sure what to expect on the day?
Yeah, for sure. I would encourage people to ask lots of questions, to attach yourself tightly to the clinician that you're going around. I've got the terrible habit of, I don't know. I know there's a med student there for the day, and I'm dead keen to have them in the room, but I'm busy and things are going on. And then my patients arrive, so I'm like, oh great, I'll take the patient to the room. Completely blank that there's a medical student with me. So please just say, hey doc, like please can I come in? Like don't be afraid, just to sort of put your hand up, and like, because often we just, I don't know, kind of. I think this is with every area of medicine, right? Like we just sometimes get a bit distracted by the day to day and the practice, but just make sure that you let them know that that you're keen, ask lots of questions. There will be many things that you don't know about, right? Like whether it comes to what using drugs do, what particular drugs are called, what the street names or slang names are, how drugs are sold, what people mean when they're talking about like, oh yeah, I used 2 points today. Oh, you're about $100 worth. Like, what does that mean when you're talking about heroin or methamphetamine? Someone's talking about like tripping or taking tabs or pills or whatever. Ask lots of questions. People who are coming to these clinics love explaining the lingo, love explaining their experiences for the most part. I mean, if someone's in tears, like read the room. If someone's in tears, if someone's clearly, if it's not the right place to ask it, then don't. But if someone's using terminology that you're not sure about, then don't be afraid to ask. I feel like so often, especially I think in these situations, people who use drugs, like you've got the doctor who's the smart, clever person who's telling everyone what to do, and then you've got the person who uses drugs who's being told what to do. That's their experience in the sort of doctor-patient relationship for almost all of their life. If there's a situation that can be reversed in some way where they are teaching you about it, take that, right? Like, because every person that we see as a patient, not just in addiction medicine, but every person we see as a patient has had unique and often fascinating life experiences. There's tons of stuff that someone who uses drugs has experienced that you have not and probably never will. And so learn from those, right? It'll make you I don't know, it's often fascinating, often kind of pretty funny at times, like hearing someone talking about this stuff if it's told in the right way. But I think will make you a better doctor in terms of learning about the huge breadth of life experience that people have. So just ask questions and listen openly. And if someone says nah, don't want to tell you that, then I don't know, don't try not to be upset or offended. Just I don't know, respect that people have the right to keep their information to themselves if they want to.
Yeah.
Yeah.
I think in clinical medicine, when we're shadowing, we kind of feel like a bit of a third wheel in the patient-doctor relationship. We're like, oh, okay, cool. And it's very, you can be very afraid to ask questions. So I think that's good general advice for any clinic as well.
Yeah.
For a medical student that is thinking about doing something addiction medicine based, or they are thinking of doing general practice, what would you recommend they do when they're in medical school?
I would recommend, look, if you're someone like me, then I'd say maybe take another year or two, like, because you can just charge in, do your intern year and go straight into general practice. And if you're absolutely fixed on wanting to do GP, then go for your life, right? Like get stuck and get straight out into clinics. If you're someone who isn't quite sure, then get more experience, do some emergency terms, do some anesthetics terms, do some intensive care, do some pediatrics, do whatever else you want to let yourself feel that you've got a good breadth of experience. When you become a GP, it'll make you a better GP because you've got all of that experience. And like if you end up finding that you want to do one of those things, I mean, whatever. But if you've done all of these different things, then you end up in general practice a few years down the line, you'll take it all, be able to reflect on that in your day-to-day clinical medicine. You'll also be able to say, oh, thank goodness I'm no longer in hospital as a JMO doing shift work.
Nice.
And you'll sort of be able to reflect positively like that, or I did anyway. And once you're into it, figure out what you're into, because you might say, oh, actually, I'm into, I don't know, general practice, in a practice where we see lots of families having kids, so we get to do the obstetric medicine type stuff, so the sort of GP maternity management plans, and then the vaccination for the young kids. You might find you like doing skin checks, so find that as an area of interest. You might find you like the HIV and gay men's health stuff or the drug and alcohol side of it. And I think pick your particular niche. Maybe you're someone who's a complete genius and just can do it all and loves doing it all. And like, oh man, I've got so much respect for those GPs. I think for most of us mere mortals, like it's good just to find an area that you really love and that you really want to focus on. And you do bits and pieces of the rest of it, but it, for me, makes it more rewarding having an area where I can say, that's a thing that I'm kind of reasonably clever in, and people might come to me to ask questions about that. It's nice having that, an area of expertise.
Yeah. I also do want to say as well, I think a lot of us going through medical school are kind of very lost, but there's always this kind of pressure because of how medicine is structured to find the thing that you are like really, really passionate about. And I think I was doing some reflecting. I was like, oh, it's probably okay if you just find the thing that you're somewhat interested in and then you try it out, and if it doesn't work out, it doesn't work out, and it's okay to like change steps in medicine. I think GP is the specialty that most allows you to do that, because once you're locked into cardiology, you're kind of like gonna go through it with it.
Can't really jump to the brain.
But general practice, as far as I can see, and all the guests that we've had on, they've had the most varied experiences, and they've had the most, I guess, interesting pathways into what they have now found. And many of them have taken a long road to get there. And when they have found it, it's all kind of made sense in retrospect. But when they were going through it, they felt like they were so behind in terms of finding the thing that they were interested in.
Yeah, I certainly had that feeling. You see your mates and they're, I don't know, like urology advanced trainees or just about to become cardiologists, as you say, and you think, oh gosh, like what am I doing? Where am I going? But looking back, I don't think I'd change it. Like I've done so many cool things and I've learnt huge amounts, whether it's through my clinical practice or through the training programs I've been through or the masters that I did. It's been great. I mean, and even now sort of thinking, gosh, if in a few years I didn't become like disenchanted with it, but thought, oh, okay, like could I learn more about something else? I could. I mean, I'm glad that my husband's not going to be listening to this podcast because like sometimes I'm like, oh, maybe I should do public health training because that'd be really interesting. And he'd probably kill me because go back to registrar age, there's all that. But I don't know, like that sort of stuff as you get a bit older, I guess does start to play a part in decision making, right? And salaries and kids and mortgages and those sorts of boring things.
Adults.
Yeah, I know, adulting, boring.
To be old.
Right. But yeah, like if seriously, like, I mean, if you're lucky enough that you've got the ability to do these things, like it's much easier from within certain areas of medicine, like general practice to shift if you want to. We're not really taught about that at medical school. It always felt to me like at medical school, you choose a pathway and that's it. You're on that path. If you deviate from that, you're kind of a bit of an aberration. But I don't know. I think it's fascinating to know that you can make changes along the way. And it left me feeling a lot less anxious about my choices once I realized that was the case. If you do something, you do it for a few years, then you want to do something else. That's okay. Life is long. Like there's a lot of time to do a lot of cool stuff.
Oh, that's so awesome to hear. Thank you so much for coming on today,
of course.
Dr. Page. It's been so cool to hear about all your experiences and you had some really great reflections. And I think we can take a lot away from this just as medical students, thinking about where we can work in the future and how we can be part of the change. So thank you so much again for coming on.
No worries. Thanks very much for having me, hey.
Nice.